Welcome to another episode of What Brings You In Today.
I'm Erica Bennett.
And I'm Taylor Fisher.
And we just want to thank you for tuning in to our podcast series. If you've not already, please like and subscribe so you can stay in touch with every episode.
And if you have any questions or topics you would like to hear us talk about, you can submit those at sgmc.org/podcast.
Today we're here with Colby Ruiz, MD and vascular surgeon at SGMC Health. Dr. Ruiz, what brings you in today?
Well, I was coming to talk about vascular surgery, but I saw Dr. Hardy already has a really thorough episode on that. So I'm really just here to hang out. I want to talk a little bit about, coming back home and being a doctor in Valdosta and, all things about working here and this community that we both love so much. So I'm excited to be here. Thank you, guys.
I love it because you actually have a rich history with our organization. Were you born here? By chance?
I was actually born in Orlando. My parents were moving up here in the process. They waited till I was 3 months old, and then they moved to Valdosta. So I've been here pretty much my whole life. Yeah, but I can't claim, born here, live here, die here. I wish I could. That'd be a cool country song or something.
I know. We do have some physicians that have been born here, though. Yeah. Some of them that are... Maybe not. Maybe just our medical students. Anyways, I digress. Yeah. But tell us about your journey because you had family that worked here.
Yeah. So I grew up here, and both my parents are nurses. So they both worked at SGMC in different capacities and different roles over the years. But when I was in high school, we were trying to figure out what to do to kind of spend the summer and not waste it. I was mowing lawns, but you can only do so much of that. So I volunteered. My dad kind of told me I was going to volunteer to come and work at the hospital. And I think I was 14 the first summer that I did it. And I was excited until I got to orientation and realized that we were going to have to wear these pink and white candy stripes. And they don't make the volunteers wear that anymore, but it was truly terrible.
I need to see photos of this because I've heard about the candy strippers outfits, but I have not seen... the outfits.
No, it was pretty bad. They were pink and white vertical stripes. It was horrible. So I just I said, when we were talking about what the options were, I said, well, what can I do and not wear that?
Yeah.
And they put me in the operating room. So that was really my first exposure to this and how I kind of got my feet wet and became interested in medicine.
Very cool.
Yeah.
I always think it's so important to get our youth involved in the healthcare field. So we interviewed Dr. Greiner on this podcast, and he said that his mom had brought him to work and in the hospital a lot. So ever since that episode, I've been bringing my children to work every day. And here, you learn about this and you learn about this, but only before they go to school because it's just right across the hall.
No, I think that's awesome. Yeah.
Expose them to, the different opportunities. So it is in your head and something that you think about.
Yeah, and it's something that, as a kid, as a child, but even later on as a student, when you're trying to think about what you want your life to look like and what kind of career you would want to do, it's hard to, you don't really know what anybody does for a day-to-day work and your day-to-day job because you don't see it, to your point. And so, there's a few jobs people think of, and of course, I want to be a doctor. That's a pretty common thing. That's one of them. But until you have seen it and experienced it, it's really hard to know what you're signing up for. So I think that's a great point. It's really important for kids to be engaged with their parents, to see what their parents do and see what their parents' friends do. And, the reality is, too, we're a small town. There's a few big industries in town, but you're not going to see 1/10 of the jobs that are available in the world growing up here. So... it's kind of cool how things come together to lead you down a path. But, the most important thing for anybody that is interested in the medical field, or really this applies to any job, but is to try to get exposure and to have goals and set goals for yourself. And once you start to identify something that you're interested in, you got to talk to somebody who's in that field and say, how did you get here? Or how does one get to the place that you're in? So you can sit down and make intentional decisions that get you there. Yeah. And I kind of joke about my dad signing me up for it, but I was curious about, medicine and thought it was cool what my parents did. I had been seeing Dr. Greiner as my pediatrician, and I kind of always looked up to him. So it's funny you mentioned him already. But there was a lot of things. And of course, a lot of kids say I want to be a doctor. I want to help people. I want to do this or that. And so I kind of set out with that as a goal. And it really was an intentional decision, even though I was 14, to explore it. And I didn't realize at the time how good of a decision it was, but it was a great way to spend my summer. I got all the experience I wanted. I met a lot of people. And what I didn't realize at the time, I mean, I knew, and it sounds silly because my parents are nurses, but I didn't realize how much of an army it takes to make the operating room run. And that was actually really valuable for me, even when I was getting into medical school and talking about that experience. Is, back in the day, everybody kind of not idolized, the surgeons probably idolized themselves, okay? But, you kind of idolize the surgeon and you view them as like the person. And still, a lot of our patients view me as the person that fixed, XYZ problem. But what you realize when you actually hit the ground and you're the one like helping to go get patients and helping to mop the floors and carrying stuff around and go and run and get this really quick and hurry back, like you don't do surgery by yourself. It's an entire team. And so being able to talk about that experience, and when you're in your medical school interviews, and I interviewed people for a little while, one of my favorite questions to ask people that wanted to go to medical school is like, oh, well, why do you want to go to medical school? And they always describe something generic. It's like, well, I like science and I want to help people. I'm like, okay, well, what is it about medical school versus nursing school, pharmacy school, X, Y, and Z? And I could list off 10 different things. Why don't you want to be a PA or a pharmacist or an X-ray technologist or whatever? And they, kind of look at you. And I got one to say one time, well, doctors make more money. And I was like, okay, well, have fun doing whatever it is you're going to do with your life.
Yeah. Definitely can't go in and purchase
the
that.
best answers is when you can explain what it is that, differentiates the role. But I was able to do that because I had seen what everybody did and looked at what everybody did. And that was
especially
cool.
in surgery, because most patients don't even know, because you get a lot of times are put to sleep and you're never awake in the operating room.
Yeah.
And so really, unless you work in those,
I think most of the time you're put to sleep.
Well,
right?
I don't know. No,
Well,
I think like a cath, like some procedures, you're in different rooms and you're
That's
not
right.
necessarily asleep.
Everybody, so
It
many
depends
people.
on what the procedure is.
They come into my clinic, and the first thing they ask, we start talking about, you're going to put me to sleep, right? And I'm like, okay, sometimes like, yes, obviously we're going to put you to sleep for this. But actually, to your point, talking about caths and stuff, when we do minimally invasive surgery, it's not like, a lot of the general surgeons do laparoscopy. And so you're still doing basically the same thing. And so you need the patients to be asleep when you're doing, some types of minimally invasive surgery. When we do catheterizations, we can have people under conscious sedation. And it's probably about 40% of the procedures I do, the patients can actually be awake and be talking to us through the procedure, which is cool. And we make sure that they're comfortable and they don't have any pain.
I would not be comfortable.
Yeah. Well, it's nice because you can have them, talk to
if
them.
they feel
Hey,
better.
how are you
Like, does this
feeling?
feel
Does this
better
make a
after?
difference? Blah, blah. Yeah, exactly.
I would freak out.
Yeah.
I would. I think I'd love it.
Yeah.
Well, speaking
we have
of,
medications to calm you down. You don't have to worry about that.
I know. I'm familiar.
Yeah.
Speaking of your specialty, what drew you to vascular surgery in particular?
Yeah.
So, well, we've already started to talk about some of it was the minimally invasive stuff. But when I was coming up here, I was seeing, a group of general surgeons that operated all over the body. And that's what I thought I wanted to do. I said, that mastery of anatomy is so cool. They can fix so many different problems, do so many different things. And once you realize there's really a lot of depth of knowledge that you need to treat disease processes. And in medical school, one of the things I realized is that, you can't be an expert in everything. And it's not that people had told me that, but you realize it the more you start to learn.
But you still thought you could. You were
Well,
like,
I'm not that arrogant. But but you start to see what they mean, and you understand what they mean. So when I was looking at the different surgical specialties, vascular really appealed to me because we really treat, roughly 3 or 4 different disease processes that can affect arteries and veins all over the body. And so they have different manifestations and different symptoms. If you have blockage in your leg, it hurts when you walk. If you have a blockage in your carotid artery, you could have a stroke. And that presents very different from a patient standpoint. But the molecular biology of how it happens and et cetera, and what medications you need to be on, and antiplatelets, antithrombotics, like that's all the same. So you learn this really, you get a lot of depth that covers everything you do. So in a lot of specialties, you work closely with like a medical counterpart, maybe a minimally invasive counterpart and whatever. So like the cardiac surgeons, they work really close with cardiologists, interventional cardiologists. The thoracic surgeons will have pulmonologists that they work really closely with and all this stuff. What I thought was cool about vascular is we kind of get to be in our own little corner, the expert on medical management, diagnostic imaging, interpreting our own tests, minimally invasive surgery and catheter-based procedures. and open surgery. And so I thought that was really cool. And what it boils down to when you're taking care of your patients is when I'm doing a procedure, I don't have to do, X, Y, or Z as the only option because I have the open surgical and the minimally invasive options. We get to really step back. And this is, my pitch to, for the specialty is that I get to step back and say, what's really the best thing for this patient in this situation? So I'm not tempted to push the limits of endovascular and just say, oh, look what we could do, technically speaking, because I can think about what's going to get this person 10 years down the road, 20 years down the road. And if you're young and healthy and you've got blockages and it hurts when you walk and you got a blockage in your leg, you're going to do a lot better off sometimes with a bypass than with a stent. And I don't have to do a stent just because I'm there because I also know how to do bypass surgery. So it's nice to be able to, see a patient and have every option to offer them. And it's not like I'm thinking, I wonder if a surgeon would operate on this person. I get to make that decision. And I have that expertise as well to apply to it. So I kind of, you treat different patients differently. You may have the same anatomic lesion that you treat 3 different ways in 3 different patients because they're at different stages of life. They have a different severity of symptoms. Somebody that has such bad blood flow that they have a wound is going to get a different operation than somebody who just gets pain when they walk. And we get to kind of
So you
put it all
like the
together.
complexity of it and all the different options and weighing.
Yeah, absolutely.
That's cool.
Yeah, I remember after we did our podcast with Dr. Hardy, he's obviously so smart, and I didn't know anything about vascular surgery, and you said that we've already talked about it. We could talk about it again. I couldn't tell you what we talked about last time because I was sitting here like, what am I going to ask him? Because I don't even really understand what he's saying.
It was very hard to ask him questions because it was mind-blowing what he was saying. You're like, wow.
Well, I just kind of want to follow that up with what's your favorite food.
Yeah.
I trust you. You sound like you know what you're talking about.
No, he's a really smart guy. He's great to have as a partner.
Yeah.
And we've done actually had him helping me out with a case this morning. So we work together a lot. But yeah, I'm here to talk about, the philosophical stuff, the fun stuff.
I like that.
It's actually, some entertainment.
Yeah.
Well, let's just touch on just a little bit of what you do treat, because I know we talked about that with Dr. Hardy, but it's good to reiterate what a vascular surgeon normally treats.
Absolutely. So we treat basically all of the blood vessels outside of the heart itself and the brain. So, people that smoke or have diabetes can get blockages in their peripheral arteries, meaning like in their legs and their arms, and they can have symptoms from not enough blood flow, and that can vary from either not enough blood flow when you're exercising, and so your legs hurt when you're walking, you get this cramping pain in your calves, to pain that hurts all the time in people with severe disease. And sometimes even, it gets so bad that the tissue starts to die and you can have ischemic wounds because your blood flow is so bad. And so we treat all of that. And another cool thing about our specialty is that we have everything in-house. So we do the wound care and we treat the complex wounds and we treat the blood flow and et cetera. We treat patients with leg swelling and varicose veins and blood clots in their veins as well. And so those frequently affect the veins in the legs, but they can, it can go to your lungs or can involve arteries or veins throughout the body. So we treat patients with blood clots. We treat patients who, this is kind of an interesting one, who are on hemodialysis and they need access to get the blood circulated in the dialysis machine. So we work really closely with a group of nephrologists in town to make sure that people have a good, reliable access. And that's actually a part of my job that I really enjoy. And there's really good scientific data that says that people who dialyze with a catheter are more likely to die sooner than people that have a functioning fistula or graft. And so to take somebody that's catheter dependent and be able to get rid of that is really fulfilling. And it's also more comfortable for the patients. A lot of times they have to take sponge baths and stuff, and because you can't get that catheter wet because it's such a dangerous thing. When they come in and they can shower for the first time because you got their catheter out after they've been dialyzing on that for like a year, people are happy. So I like that reaction a lot. So that's a couple of things. We've talked about veins. We've talked about arteries. We've talked in the legs. We've talked about dialysis access. So another common one, we see a lot of patients that have had strokes or are at high risk for stroke who have narrowings in the arteries in their neck. And we have a few different ways that we can clean those out. So that's pretty cool. And then, depending on how bad it is, if they've had a stroke or if they've had many strokes or certain symptoms, we can reduce their stroke risk in the next 5 years from 25% down to less than 10% by doing that surgery. And if it's somebody that has an asymptomatic blockage, but it's a bad blockage, we can take their risk from about 11% down to less than 5%. So that's one of my favorite operations to do. It's stressful, don't get me wrong, to take somebody who hasn't had a stroke and do a surgery that has a very small risk of causing a stroke to prevent them long term. But, fortunately, we've been very successful. We have a very good carotid program here and a great team, and we've had good success with that. So that's another one. And then aneurysms is really complex, and it's kind of a hard thing to wrap your mind around. But I think of it as like you're blowing up a balloon. And as you're putting more pressure, the wall is actually getting weaker because it's getting thinner. And the reason it's expanding is to decrease the wall stress that's spread out over any one area. It's kind of some complex physics. But the point is that as that balloon gets bigger, it's closer and closer to popping. And if you think about a blood vessel and the wall's getting weak and it's getting bigger, it's telling you that it's on its way towards rupture, which can be catastrophic, as you can imagine. And so we do some minimally invasive procedures and open procedures to repair aneurysms, most commonly involving the aorta, which is the biggest blood vessel in the body. So that's pretty exciting surgery, and can make a big difference for people. And then we're here for emergencies. So we've since I've been here since July 15th. We have treated 4 or 5 patients who actually came in, didn't know they had an aneurysm, came in with a ruptured aneurysm. And so that gets a little bit crazy.
What does a ruptured aneurysm do? How does that present? Obviously the
sad statistic is that 80% of people that have a ruptured aneurysm involving the aorta don't even survive to the hospital. So we get the people that have survived to the hospital and they're coming here either transferred from another institution or occasionally they'll show up in our ER. But a lot of times it's either severe chest pain or abdominal pain, and then they'll pass out. And that's how you know, because your blood pressure just dropped. And so the faster that they could get here, the better. And ideally, we like to find it before it gets to that point. We can talk a little bit about other reasons I like vascular surgery, but without going on a tangent about me, focusing on the patients, it's really important for people that have ever smoked, especially men, but the disease occurs in men and women, to get screened when they turn 65 on their Welcome to Medicare exam. And so Medicare will pay for it. Definitely in male patients, and then in female patients where our society is still working with CMS to get that approved, because women have aneurysms too. It's just a slightly lower rate than men. But they say if you've smoked 100 cigarettes in your life when you turn 65, you should be screened, because CMS and all the major surgical societies that work with us has identified that this is a very high risk of mortality, and it's a common enough disease process that it merits a screening exam to get checked. So that's the best thing I could tell people listening is if you fall into those categories, it's where the screen. And then people that have family members with aneurysms or, a family member that's had a rupture or something like that, they need to be screened at a younger age. And I would say, there's no guidelines, so to speak, but, you should be screened 5 to 10 years before your sibling or one of your parents
how does that screening work? Is it like a full body scan, or
it's very simple. They just come in. We actually do it in the office. It's an ultrasound. It's just like, looking for a baby in there. They just put the ultrasound probe on, do a quick scan of the aorta, and people are in and out in 15 minutes. Wow. So it's a really simple thing that can save you from a bad problem.
Yeah. Well, especially like you said, because it's hard to come back from that because it's such
absolutely. And I like our specialty because there's so much. You get the variety. So there's some cases that come in. I really enjoy the planning, and you can spend hours with a CT scan thinking about every meticulous detail of how you're going to fix something, what order you're going to do things, how you might vary from your usual routine, and how you need to set up to be prepared to do that. And then somebody comes in ruptured, you have 13 seconds to look at the scan and make a plan. And so you have to be so good at it that you can do it that fast. But I like it better when, they're elective and you can take your time and really make sure you nail it and get everything perfect. Not that we can't fix the ruptures. I remember this
from Grey's Anatomy.
Yeah.
There were several, I think they called them AAAs, abdominal aortic aneurysm.
There you go.
And that was always a big deal in Grey's Anatomy. Like, they never thought that they were going to save that person. So it's kind of the same thing because I've watched Grey's Anatomy, so I kind of...
Yeah, obviously.
Well, yeah, that's right. That's right. Well, you got it. We're on the same page talking about this. It's a big deal. No. But we are, we do have a very successful, track record in treating those. And the surgery is so simple to fix it. You'd be shocked if you have one. And we talk about it. It's technically complex, but it works really well. And people are back to work or back to their activities within not even 6 weeks, 4 weeks most of the time. So I like doing that.
Well, thinking about your career or you're getting to where you're starting your career, you knew you were going to be a physician, and then that's a long school. A lot of education. And now that you finally, kind of tell us how many years, now that you're here, how does it feel to be able to be, really getting into the grind of things?
Well, the feeling on this side is awesome. And every time I think I'm having a bad day or a tough day, I look back. Actually, my little brother is doing the same thing as me. So I'll call him and hear about what he's doing. And I'm like, oh, man, thank goodness I'm not in residency.
You survived.
No, so I did everything that I could to get here as quickly as I could because I kind of knew what I wanted to do. And then towards the end, I knew Dr. Hardy was here, and I knew that he was ramping things up, and that I had the potential opportunity to come and join him. So that was kind of in the back of my mind the whole time. But I graduated high school, and then I went to the University of Georgia. So I was 4 years at the University of Georgia. And I studied in the agricultural school, biological science of agriculture. So that was cool. That was a great experience. Georgia did a lot to get me set up for success in medical school. Like I said, you have to be intentional and you have to know what goal you're trying to get to, but the opportunities are, huge there. So I went there, had a couple options. I chose to go to the University of North Carolina for medical school, and I had a really good experience there. And that was another 4 years. So that's, we're at 8 now after high school. And then I was looking at residency options, and there's 2 ways to become a vascular surgeon. You can do 5 years of general surgery and then a 2-year fellowship, or they have an integrated training program where you do 5 years to do vascular. And it's similar. Like your first 3 years, you do a lot of general surgery rotation, so you still get a lot of the relevant experience from general surgery that applies to vascular, but you spend a lot more time on vascular the whole time. So, in my first year, it's called your intern year. I think I did 4 or 5 months on the vascular surgery service, and then the rest of my time was various rotations that are in general surgery that are relevant to what we do. And then my second year, it was 6 months. And then my third year, it was like 7 months of vascular. And then my last 2 years, I was basically the equivalent of a vascular fellowship. So I did 5 years after that. So all in all, it's really... if anybody's interested, it's the best deal in surgery because most people do a fellowship after their general surgery training. So I shaved off 2 years doing it this way, and it was 13 in total, so 8 plus 5.
I was sitting here trying to add that together. I'm not good at math. I was
we
like,
can't
that's
tell
13
any
years.
children, though, how long it takes to become a doctor because they will know.
But I'll tell you,
Seems so long, but obviously you have to do it that long to get good at it, to be able to feel good about it when those emergency situations come in.
Yeah, and it really all boils down to those last couple years when you're doing vascular surgery every day and you're doing more and more independently and being at a good training program. I was very fortunate to be able to be with some really good vascular surgeons that I look up to a lot in a lot of different ways. But that was really... the meat and potatoes of training is the last 2 years. You have to spend all this time. Like if you go sign up to work, you want to work in a 5-star restaurant or whatever, 3 Michelin star restaurant. There's no 5 stars, 3-star restaurant. And you walk into the kitchen on your first day, you got to show them that you know how to, chop carrots and onions proficiently, make stuff look pretty before they're going to let you start plating, before you ever touch anything in the kitchen where you're cooking, before you're ever designing a menu. So you have to have like hundreds and hundreds of basic skills and a knowledge base to take care of patients before you start to actually get to, do anything. So the last 2 years really culminates the training. But fast forward to coming down here, obviously it's nerve-wracking because you're like the ball's in your court. It's all your responsibility now. But I was so thankful when I got here I'll tell a quick story about Hardy since he's not here.
Since he's not here to defend himself.
That's right. No, so he was in clinic. It was a Monday. So I got here on a Wednesday. It was my first day. And I had go around and meet some people, get my badge, see where the scrubs are, stuff that I kind of knew because I was here, but I had to retrain. And so that was Wednesday, Thursday, Friday. I think Friday I scrubbed in on one of Hardy's cases and helped him out for 5 minutes. It was fun. I was like, okay, this is going to be nice. I'm just easing my way into it. Monday he had clinic. He was on call. I'm in the office just looking up patients to get ready for my Tuesday clinic. And he at lunchtime he called me. He was like, hey, I'm down here in the ER. I'm seeing somebody I think probably needs surgery. I was going to cancel all my afternoon patients, but if you want to take care of it, that'd be great. And I was like, yeah, sure. What's going on? He was like, oh, just come down here. Doctors are NP. He's like, doctors getting them set up. I get down there. It was an absolute disaster. This poor man had a ruptured, infected femoral artery aneurysm. I actually just saw him this week, and he's just now completely recovered from this. Okay, it took a long time. Yeah. So I got down there, and I was like, man, this is going to be a problem. So we ran to the OR, and it was an absolute, it was a life-threatening situation. Yeah. It was basically a ruptured aneurysm in the groin rather than in the belly, but there was also the infection component. So it was, several hours of surgery, getting that all repaired, get him to the ICU, getting him better. The next day we took him back and did some complex stuff to get the wound to close and heal. And he just, he came into clinic Tuesday and just completely recovered, which was a long road for him. But that was my introduction to South Georgia Medical Center. Yeah. And I ran into Dr. Ziegler in the lounge afterwards, and he was like, hey, how's it going? What you been up to? I was like, I just did something I've never seen before. I've had a case I've never seen before. He was like, you better get used to that, buddy. Right. This is Valdosta.
And that's how we recruit a lot of our physicians because you do have the opportunity to see so many different things because of our population that we have here. So, but
it's not that, I guess to the point, to finish the thought there, before we move on, I say I've never seen that before. I've seen a lot of similar things, and you have this skill set. You have, a toolbox where it's like, I know how to do this, I know how to do this, I know how to do this, I know how to do that. You got all these options and things you can do, and you know what's good in which situation. That's one of the really fun things about what we do. It's very common to do something that you've never done before. I did that this morning when I was running over here. It's about I've done every piece of it before, so I can put it together to do what the patient needs. And so that's what it was. When I got through that case, I was like, this is actually going to be pretty fun. Yeah. And it has been. And so I've had a lot of really good support from Dr. Hardy and from my other partners in the cardiovascular group. I've got, built some really good relationships with the physicians that are here. And it's growing, and they're keeping us busy. And the cool thing is that now, I've been here a short amount of time. We're already seeing substantially more patients than Dr. Hardy was able to see on his own. And so we really are starting to grow it and being able to get to people faster. And it's just an exciting time.
That's exactly what I was going to say, is the fact that he didn't have to cancel his patients and you were able to, step right in. Because his
clinic is booked out 6 weeks. If you're a new patient, well, both of us, if you're a new patient, you want to see us, it might take 4 to 6 weeks to get you in a slot. That's come down since I got here substantially. But at the time, it was like we're just it really kills the system. It really hurts people. Those patients that are waiting to see him if we don't keep moving. So now that there's two of us, every emergency doesn't derail your entire day. We can take turns, cover for each other, and it really makes it function more efficiently. So it's good to be here.
Very good.
I think that's wonderful. I think we've covered so much. I did want to ask if you had a memorable patient story or anything that sticks out to you that you've seen that was maybe rare or just interesting or something like that.
Yeah, well, we cut off, we talked about probably 80% of stuff that we do. So I'll say there was, kind of talking about other things that you wouldn't expect a vascular surgeon to necessarily do or whatever. We had a patient that was here that was really sick with a GI bleed, and we tried everything medically to try to get it to stop. They were doing a really good job at requiring a lot of blood transfusions just to keep him alive. And it was like, hey, we're at a point where this isn't sustainable and we're reaching the end of what we can do. So they called me when we had a CT scan. We couldn't see where it was bleeding. So I worked with the ICU, worked with the GI medicine team, worked with the medicine team. We got him stabilized, to the point that they could do an endoscopy the next day. And so they took him and did an endoscopy, and they said, hey, there's this huge blood clot sitting on this duodenal ulcer. We can't take it off to go see what's underneath it because we're scared that if we do that, it could be a really big problem we can't fix. So we just left it. That's what he's got. So I sat down, looked at the CT scan, and I talked with Dr. Hardy, talked about the case. We talk about, 80% of the patients that either one of us operates on, we have a conversation about, which is a really cool part of being part of a small group because we're so close. We talk about everything. We bounce ideas off of each other. I'm surprised at how much we're on the same page, and it's cool to see the common threads in training, which we can. Yeah. We had one guy that trained both of us that we took a lot away from, so that's part of it. But talked to him about the case. Said, "Here's what I see," blah 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 blah. And this is a Sunday night at 7 p.m. And I said, "This is what I think I need to do. I'm going to try to go get in this branch that feeds that area and embolize it or shut it down, basically with these little coils." And he was like, "Well, I'm not doing anything. I'll come up there and give you a second set of eyes, second set of hands if you want." So he came in and watched me do it, and we were like, hanging out and talking the whole time as we're working. And I was able to get into this small branch, and I said, "What catheter would you use here?" And he told me, and I put it in. It just went right where we wanted it to go. We dropped the coils, and then the guy he has not required another unit of blood since then.
Wow.
He's actually leaving the hospital today. It's been a week and a half ago. So that was pretty cool. So there's all kind of interesting situations that we can get involved in that you wouldn't expect. But
isn't it cool to be able to work with good people? And
oh, yeah.
I mean, I think that makes you spend so much time at your job and in your career. And I think when you have the right team in place, it just makes the world of difference for everyone. So I think that's cool. So,
and our quality of life has gone up too. I know he was just like working around the clock, and this is a great place to work. It's a great place to live. In the last week, I think I've missed dinner one time to be up here working. So it's really kind of everything that I wanted out of a practice. I've got great support from the hospital and from my partners and colleagues. It's a really solid group of physicians working here.
Yeah. And we're growing. We've got a lot of new specialties coming in and stuff. So it's an exciting time to be a part of this organization.
And then all the training we're doing too. I mean, we have the residency is about to graduate their first class. We've got more and more students. Now we have 1 to 2 students every week working with me and Dr. Hardy. We're just one little island in this big hospital. Yeah. So it's cool to see that aspect growing. None of that was here when I left 13 years ago. Yeah, I was like, so it probably meant I got more attention as a volunteer because I was like very curious. But anyway.
Well, I think we're at our time limit. It went by fast. But I do want to say, just for anybody that is interested, we call it the Canopy of Care now, which is the program that Dr. Ruiz is mentioning, but I think it's 14 to 17-year-olds, and they can volunteer like 6 or 7 weeks throughout the summer. So if that is something you're interested in, we will link the application or at least the page for that below, and they can apply for that to participate during the summer. So it is a good.
It very well could be the most valuable thing you do all summer.
You might need to talk your kid into doing it because you might turn into be a vascular surgeon.
Yeah, so you can come hang out with us. He or she.
There you go.
Well, I also want to ask, since you are so familiar with this place, what is your favorite meal to eat here?
Oh, every Wednesday, it's fried chicken, banana pudding. Easiest question I've had all day.
Yes. That's a fan favorite for some people. I feel like some of the physicians don't want to admit that they eat the fried chicken. So they try to think of like a healthy option.
Yeah. There are healthy options, which I appreciate, but Wednesdays, I don't mess with them.
Yeah.
You can eat fried chicken on Wednesdays. Yeah, once a week.
Yeah.
Exactly.
Good. All right. Well, thank you so much for joining us today.
Absolutely.
Thank you to all of our listeners for joining us. And we just appreciate it if you like and subscribe and get the episodes downloaded every time we release them. And if you have any questions, you can submit them at sgmc.org/podcast.